Hello, everybody. Anish and Michelle here. Hi, Anish.
Hello, how are you?
I'm fine, thank you. Thank you. Today we're going to talk about public reporting. It seems to be a hot topic, at least in our circle on Twitter.
Yes.
And I'm going to give a little background on the conversation. A few days ago, a paper came out in JAMA. The lead author was, or the senior author was Bob Yeh, who's an interventional cardiologist at Harvard. And the paper is a survey of cardiologists about their perception of public reporting of outcomes and whether public reporting inhibits cardiologists from taking on high-risk cases. And the majority of the cardiologists, the interventional cardiologists surveyed, said yes, it inhibits, they're less likely to take on high-risk patients because of this public reporting issue. So in response to that paper, Harlan Krumholtz, who's, for people who don't know, who's a real guru of outcomes research and influential in health policy, especially in health policy designed on the basis of outcomes research, expressed on a tweet, a real surprise. He said, "Really? How can that be? Would cardiologists be influenced by public reporting and fail to treat sick patients? I find it completely unbelievable." Or maybe not completely, but he said, I find it extremely surprising, and I really would like to know if there's any data to support that contention. So,
Right.
In response to that, Bob Yeh, the author of the paper, just tweeted a long, a series of tweets laying out, the position and essentially saying, to begin with, we know that once public reporting programs are implemented, the rate of intervention decreases, particularly in response to and the rate of interventions in sick patients decreases. Patients with cardiogenic shock and high-risk patients, they seem to get less, fewer interventions once public reporting is initiated. And conversely, when the public reporting policy is modified and liberalized so that patients in shock are no longer included, then there seems to be an increase, an uptick in those patients getting cardiac interventions. So that speaks to an influence of public reporting on practice patterns. And then he published another paper. He tweeted about another paper by Ashish Jha, essentially supporting that fact, but showing that mortality does not change, even though the rate of intervention following public reporting seems to decrease. Mortality doesn't change, and blah blah blah. And then he had a little survey on Twitter asking cardiologists what their perception about public reporting. Does it influence your eagerness to take on a sick patient if you think that your outcome might be adversely reported? And the majority of the cardiologists on Twitter said yes, and so forth. So that's essentially the meat. And following that, there was a discussion about what should we do about it. Should we scrap public reporting? Should we modify it? What should public reporting be like, and so forth? So what are your thoughts? I know that you've written about that. I think a very powerful anecdote. But a very powerful story that you published on the healthcare blog.
Yeah, no, I wrote a story about Joseph Kerrigan, a patient of mine that showed up with an infection of his aortic valve, and infection was eating away his valve. He needed surgery done, and I wasn't able to find a surgeon in the city that would operate on him. And I spoke to multiple surgeons in the city, and they all said that we live in a new world of public reporting, and this is why we're not going to take this patient.
Right. And you live in a state in Pennsylvania. You practice in Pennsylvania, which is one of the states that has mandatory public reporting.
Yeah. Yes. Exactly. And they've had mandatory public reporting for CT surgery specifically for many years. Now, interestingly, there's a carve out for endocarditis. So the state public reporting actually does not include endocarditis. But this is the fascinating thing about it. The culture change is such that. That's everything. And there are national, because there's so, public reporting is so in vogue and everyone is supposedly looking at public reporting, there are national registries for CT surgeons, something called the STS database, I believe, is what the surgeon told me. And in those national registries, public reporting, you report you report your mortality. So
right.
just in general, a chill towards taking folks that are very sick. Joe was a sick. He was a 52-year-old man, but he was sick. He was on dialysis. He did have some liver disease, and that was in the early stages of cirrhosis, and with something that was treatable, hepatitis C that was treatable now. But regardless, somebody who I think no-brainer would have been operated on 5, 6, 7.
Right, because the alternative to not operating is certain death, right? I mean,
certain death, exactly.
Pretty much,
exactly
right.
But you don't want to be a program that has the highest mortality and then the highest mortality in the area. And it's very, very corrosive because and everyone is trying to do the right thing and is well intentioned. So they mentioned, the surgeons I talked to mentioned the fact that there was a newspaper article that was done recently by the local newspaper, and the local newspaper had published the various outcomes, and the major large academic quaternary care center that sits there that does that, everyone in the city knows is they're probably the most experienced, and the volume wise certainly they do the most. They do probably the toughest cases in the city. Those folks are now skittish because this recent article put them behind some of their other hospitals that don't take care of as sick a group of folks. And so it speaks to many, many, many different things. It speaks to the fact that the scores don't really mean anything. I mean, if a cardiologist like me knows that, hey, if I have a really, really tough sick patient, that this is the best place for him, and the public reporting indices and scores disagree with that, I don't think I'm the one that's wrong. I think I think the scores are not correct, in large part because risk adjustment is very, very hard. So these scores are risk adjusted. Obviously, it's not raw mortality numbers. It's adjusted for how sick of a patient population you're taking. And unfortunately, that's incredibly hard to do. You can't just take age. You can't just take the presence of acute renal failure or not. You can't just take the presence of cirrhosis or not.
Yeah, I mean, it's not that it's hard to do, it's that it's impossible to do. I mean, frankly, yes, there's a little bit of a statistical, magic powder being sprinkled on the data. Right. But it's really meaningless. And that's where I think I wish the quantifier people were more straightforward about it, because they say, oh, we do statistical adjustment, but that's baloney, as far as I'm concerned.
Right. And
especially when when all it takes is just because mortality from cardiac surgery is quite low, in general. So really, all it takes is just a few deaths in a program, a couple of deaths or 3 deaths, a year, depending on the size of the program, and there you have it. And this business about risk adjustment, really, I mean, everybody knows. Right.
And the surgeons know that. The surgeons know that these patients are not going to be risk adjusted appropriately.
So what they do, they do their own risk adjustments. They don't trust the method to risk adjust, and therefore they risk adjust themselves by not taking on the high risk patients.
Right. So Harlan Krumholtz is, I mean, I'm shocked that he's not aware of what's clearly happening. Because you're asking surgeons, sometimes young, sometimes whether they be seniors, whatever level they are, you're asking these surgeons to take possibly big hits on their career, and they are, they know these patients are incredibly ill, and there's a high chance that things won't work out well, and so they choose not to operate. I don't know. Right. I don't know what he seems to say, that the ethics of the physician are such that he cannot believe that this is what is happening. What do you think about that, Mr.
Yeah, I mean, right. I mean, I don't know. I don't know what to say. I don't know if it's ignorance or if it's being disingenuous. Because
but what do you think about his point? What do you think about his point in terms of why is it that physicians are like, should we? I mean, as a mass, if we said screw the scores,
right? But we're not as a mass because we're there's competition, as you said. There are, programs are competing. So a surgeon works in a hospital, or an interventional cardiologist, you work in a hospital. I think, so far as I can tell, it's not directly the patients, the physicians that are named. It's more global. It's more of the program. But nevertheless, if you have if you take on, high risk patients and the patients die in the hospital, and it reflects on the program, then you're going to be under pressure from your colleagues or from the administration,
Right.
to.
Does it reflect a decline in professional ethics that we are? I mean, do you think 40 years ago this would have happened? Like, what has happened? What's different about physicians now? I mean, I guess maybe, who knows? Maybe it would have happened 40 years ago. Do you think there's something different about professionals, physician professionals?
You mean whether? No, there's nothing different.
That they can be pushed around now.
You mean if the public reporting was implemented 40 years ago, would the reaction have been different?
Yeah.
No, it wouldn't have. I mean, it's human nature, and it's, we can't say that all physicians are influenced at all times to the same extent, but it's an influencing factor. I mean, and to deny it,
I think
it goes against.
I wonder.
We accept that physicians are influenced by all kinds of things, right? By advertising, by pharma gifts, by sandwiches from Merck and whatnot. Yeah. And so why are we sort of surprised that they're influenced? If they are going to be.
I wonder if it has something to do with the fact that physicians are now employed to a much greater degree by health systems. So whereas before, the patient who shows up at a CT surgeon's door or whatever proceduralist door, the contract is between him and the patient, and now the physician serving multiple masters, and there is really one master.
Correct.
One major master.
I think that's right. There is certainly. There was more competition 40 years ago, 50 years ago, on the basis of reputation alone. I mean, maybe not alone, but on the basis of reputation. Reputation from peers was more important, and therefore the doctors who were willing to take on high-risk patients, if it was recognized as being appropriate by colleagues, then their reputation would gain, and therefore they had an incentive, and perhaps even if a public reporting system was present at the time, it would have had less of an impact. But now, of course, it's not the case. Physicians are more and more part of larger groups, so the individual reputation is subordinated to the reputation of the group or the medical center itself, the hospital. Patients are now more tethered and by their health plans, so they have to go wherever their health plans tell them to go. So they pay less attention to the reputation of the doctor. They just go wherever they're allowed to go. But that brings up a very important question, because what's the point of this public reporting? I mean, the initial reaction is that it must be for quality, for the good of the public, but no. I mean, I think it's clear. It cannot be that it's meant for the public, even though it's reported publicly. It really cannot be. There's no rationale. It'd be completely unbelievable that we would expect the public to go and look at the databases and understand, what it all means, and then make a decision on that basis.
Right.
When in fact, the whole system, our licensing system, and the way our, hospitals are given licenses and doctors are given licenses, assumes that the public cannot tell the difference. So we cannot say on the one hand, but the public is, unable to decide. Therefore, that's why we need licensing systems and certification. And at the same time, say, well, now we're putting the data out there for the public to make a decision. So it has nothing to do with informing the public.
Yeah, I think it has to do.
What's that?
I think it has to do with informing the payers.
That's exactly right. And so it's not. I did a little bit of. I looked at a little bit of the history of public reporting, and if you do a search if you enter the search term public reporting on PubMed, there's very little that shows up until about the year 2000. Okay, and there's a little bit in the 1990s and nothing before then. And what happens is in the 1990s, public reporting was actually pushed by the people who were pushing for the Clinton healthcare plan. Right, so that's when it really emerged, because part of the idea was that the Clinton reform in the early 1990s was they were going to force, or mandate that every person in the U.S. would have to belong to some kind of managed care HMO type thing, and the public reporting would be there to allow the payers or to allow the government. I'm not sure. I don't know what the details were, but it's clear that was the
Right.
the impetus.
Yeah.
And then the whole thing fell apart in the 1990s, but it was resurrected. It had a second wind when the Institute of Medicine, the IOM, published, its famous, reports, about medical errors and so forth. So then that's when you see, the start of a big surge in public reporting. And there's, I have a quote here from a paper, from 2003. So from, 15 years ago, about public reporting and, what are the key drivers. And it says, first, high quality care, blah, 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 which it can be. I mean, it doesn't, we can't prove that it improves quality in any way. But secondly, it says, there's a rapidly increasing interest in the use of tiered pricing, for health plans. So that really, when you have public reporting, what you end up getting a bell-shaped curve, and then you can divide that bell-shaped curve. Says everybody on in the top tier will get preferential pay, the ones in the middle will get this, and the one in the lower tier will get a warning, and maybe we won't pay them at all, or we'll shut down the. So that's really the goal, and it's really terrible, because many of these measures, when you look at them, so first of all, what kind of measures? They use things that are, because they want consensus. They don't want measures that are too controversial. They use things that, everybody does. I'll give you an example would be, it's not a real example, but imagine them using hand washing as an example, right? So 99.99% everybody does hand washing. The curve is very, very tight, but nevertheless, there's a little standard deviation that somebody, for some reason, didn't wash his hand before operating, or her, and so forth. And it's, but nevertheless, so there's always a distribution, and you can always get, tiers and tier your payment according to that.
Right.
And number two, for the things that are more controversial, where there's more, a greater disparity in practice, then there's no backing of why the disparity is bad, and who, whether to be on that side of the distribution is better or worse or not. I mean, these metrics about PCI. I mean, that's one thing that Bob Ye, who's I think right now an expert as far as cardiologists are concerned on public reporting, said there's no metric, there's no possible metric for the quality of that captures the quality of PCI.
Right. No, absolutely.
Correct. Everybody knows it. Everybody knows it, but they keep on sharing. So the health outcomes people, people like Harlan Krumholz and whatnot. So all their papers, if you read them, they all follow a certain pattern. First of all, they all start almost invariably. They mention Florence Nightingale at the beginning. There's always a reference to Florence Nightingale. Why? Because it's a little bit of virtue signaling. Because everybody, who can be against Florence Nightingale? And apparently, Florence Nightingale, in the Crimean War, in the 1850s, she did, she agitated for public reporting of outcomes. So they start by making reference to Florence Nightingale, and then, they go into, yes, risk adjustment is difficult. Yes, the outcomes don't capture the totality of care. Yes, the system can be gained. Yes, this and that. But, if we all work together, if we all, put our goodwill for this, we can do it, and let's keep on doing it. And they keep on doing it. So they keep on doing it despite the fact that they know absolutely firmly that it's a bunch of baloney. And patients get hurt, and patients, like in your case, can die, and no impunity for the policymakers and the policy supporters.
No,
in fact, it's the intention is essentially it's a covert form of rationing. So you try to influence the doctors from not taking on those high risk cases.
Right. Yeah. No, I mean, there's so many. It touches on so many different points. But yeah, the father of CMS, the precursor to CMS, the Healthcare Financing Administration, 1984, is the one who first came out and reported on mortality in a bunch of different hospitals, in 260 hospitals. And then there was such a massive outcry, even though these were also risk-adjusted mortality numbers. There was such a massive outcry after they did that it was they actually stopped publishing it. So there's hope. We have published. We have.
I don't know. So there's a difference now. So the difference that back in the 80s and 90s, it was done without academic input and without really input from the professional societies. So it was really the health policy guys who just started to publish outcomes, and then there was an outcry because but now, unfortunately, as you mentioned earlier, there's cooperation by the professional organizations that allegedly represent the doctors. So you have the STS, the Thoracic Surgery Society, that has its own database, and for the cardiologists, there's the American College of Cardiology publishes a database, and these databases are, quote unquote, voluntary, but there's a lot of pressure on programs to participate in those registries, and they inform policy at some level, and so now the professional societies, the people who lead the physician organizations, first of all, they make a lot of money. I don't know. I just sent a tweet asking people if they knew how much does it cost for do you have any idea how much it costs for a hospital to participate in the STS database program or in the NCDR database program? I'm pretty sure they pay a hefty fee. I wouldn't be surprised. They pay just for the privilege of reporting the outcomes. And the professional societies will say, oh, but, you'd better report the outcomes through us, because if you don't do it through us, then, it'll be the bad guys doing it. But the methods are not any better, right? The methods are equally bad. They're equally poor and meaningless.
Yeah.
So,
here's
less of an outcry, because now the academic leaders and the professional leaders, seems to have found that is in their interest to keep the shit going.
But the amazing thing with the one little tangential point here is that Twitter and social media has really opened up the discussion a lot, because it used to be that you have these healthcare policy folks that had a lot of credibility in this space because they're the only ones that were publishing in this space. So they're publishing all this data, showing the public reporting, and essentially there's an ideology that they support, which is that regional variations. There's lots of regional variation. Variation is bad. If we standardize care, we will improve outcomes. And if we just publicly report, we will be able to identify those that are laggards.
And the outliers, and
if the outliers just do systemically, Systema is protocols and all have hand washing checklists.
Central planners and managers.
But, and they found a receptive audience, and the School of Public Health, that churns out however many graduates a year. They found a receptive audience in legislators, right? Because who else is talking? They're not. We are not talking. We don't have a voice, and they are the evidence-based. They have all this evidence that they publish. So it seems to folks that are lay people that are in charge of making policy that these folks are doing what's scientific and what should be done. But now I think you're really starting to see. Harlan Krumholtz says this, and there's a fairly large number of cardiologists that say, this is not how it's going. He says, where are the anecdotes? I can't believe that cardiologists do this. And, there's an immediate response of all these different anecdotes. I tweeted him my piece and said, hey, look, here's an anecdote. Here's what actually happened. And, with permission from the family, I said, let me know if you want their contact information to confirm all this. So
right.
She's starting to see change in terms of, and hopefully the policymakers will see this commentary, will see this discussion, and get the sense that things are not as ironclad as some folks who have dressed up ideology with evidence would make it. But
maybe. You're optimistic. I'm less optimistic. I don't know, because then they will come back and say, well, okay, it's imperfect and blah blah blah, but what else can we do? Right?
Yeah. So
what's the alternative?
Well, here's the question. Khurram Nasir is another cardiologist who is also a supporter of some type of public reporting. He says, look, all this whole discussion, this backlash from cardiologists who are public reporting is all well and good, but we have a problem. The problem is that there are bad actors out there. There are folks that are underneath the standard of care that are hurting patients, and what do we do about them? So what do we do about them, Michelle? How do we police ourselves?
Well, what's remarkable is that the reason the question is, how come they're still in business? because I mean, if everybody knows that they're having bad outcomes, how come what's keeping them in business? And that's the problem that nobody wants to talk about, is because they're keeping it business. They are protected by the system. So on the one hand, the system keeps bad actors, promotes bad quality of care by removing the patient, by shielding the patient from decision making, whether it's through financial subsidies, and health insurance and whatnot. It essentially shields the patient from being a more critical judge of quality, and through licensing and through all these things. I mean, it's a whole culture that says, oh, don't worry, all these people are licensed and they have board certification and they comply. Now they're on their report, on our reporting, by our reporting measures, they do very well. Somebody tweeted that, the worst offenders probably have the best scores on the reporting measures, which, I wouldn't be surprised. That's true. Because, if you take, for example, the people who operate on, or who do angioplasty on people who barely have any coronary disease, and some people have been caught like that. Well, these are very low risk people, and so they're going to have very they'll have very nice results, low operative mortalities and that sort of thing. So there's a system that keeps the patients in the dark and all that. I mean, there's no easy solution, because the system is so, it's been decades and decades of building this. But
Michel, even we've always had bad actors, even
correct.
Even when third-party payers were not as prominent as they are now. We've had third-party payers that are prominent for a long time. But how is a primary care physician? Say we have our dream world, which is a bunch of independent actors, and patients are paying, if not the whole thing, if they're paying significant chunk of whatever procedure it is that is being recommended. How is a primary care physician or a patient supposed to figure out that you, Michel, are somebody that I should be sending my patient to for a procedure?
I mean, if we're talking about really having really bad actors, I mean, if we know that they exist and we know them, it means that it's evident without needing to run any kind of tests or metrics, meaning that this guy is operating on patients he or she shouldn't operate on, and are having complications when they shouldn't have complications. So if that's known to the referring physician, to the community of doctors, then the colleagues should stop. Normally, I mean, if I'm referring a patient of mine to a doctor who has bad outcomes and a bad outcome, I mean, it's going to reflect poorly on me. It should. I mean, in a normal system, it would reflect poorly on the referring physician, and the referring physician would be a natural check on quality. So now it's not happening because there's built into the system, as I was saying earlier, but it's long-standing, built in the system, incentives that keep these, the bad apples operating, and they can keep operating for a long time. And many times they keep operating because they benefit the group, they benefit the hospital. Sometimes you have, really bad people, but they do a lot of procedures, and that generates a lot of income. And so it calls into question, the problem is that the solution means really rethinking the whole system, at its roots, and nobody's willing to do that because there's no practical. There doesn't seem to be any practical way of doing that.
Yeah, right. We're not as willing to burn down everything as you are, Michel.
But I mean, I'm burning it down by. But what I'm doing is that I'm limiting my practice. I mean, I'm not really essentially. I've curtailed my in-hospital practice, and so forth. So I'm not a practical example for a solution, unless everybody sort of, did it all together. But I can't imagine it happening. I can't imagine it happening. It's a tragedy. Some other people have said on Twitter. People said, well, we should have. I think Edgeloss and Sunil Rao have said we should have maybe, peers do some kind of peer review for quality, but I can't imagine that happening. What are your thoughts about that? How would you select those reviewers, to review?
Well, just even if you knew that there was a random selection of your cases that were subject to review, I think that would make a lot of people think twice about, say, stenting. I'm talking about egregious things. This is the other issue that we should talk about, that I think is interesting. That the problem is that a lot of the the question is how much variation should one tolerate? And I think I'm getting the sense that the amount of variation that I would tolerate is a lot more than, say, Khurram Nasir would tolerate, is my sense, meaning there's a wide band of
Right, correct.
things. So
Correct.
that,
Yeah.
and there's a lot of stuff that goes into those decisions that go beyond just what is objectively obvious to see.
Yeah.
So,
And who's going to be selected? Who's going to be selected to be a reviewer? I mean, who's going to decide who's a worthy reviewer, right? I mean, why?
well,
By what mechanism?
The neurosurgeons have started to do something very interesting. I was talking to a neurosurgeon recently where they have a very intense certification process where when they get their initial board certification, at least now, that there is a random sample of cases that are pulled that you have to show. And so you have to go through what the imaging was, what was documented as being their exam was, and then the surgery
to the board of neurosurgery.
To the board, there's a panel of 3 randomly selected, people. I guess they have a rotating board or something like that. And so you go and you have to then go defend what it is you did in this. And there's some people, and interestingly, I was told, again, this is all passed to me, not published or anything like that. But I was told that there were some neurosurgeons who flat out said, probably looking back this, I shouldn't have taken this person to the OR. So under that line of questioning, they said, maybe this was a case that shouldn't have gone to the OR.
Right. I think that's reasonable. It's a reasonable approach. But again, neurosurgery is a very small community. I mean, I think if they can still have oral examination of physicians, in neurosurgery on a national basis, okay, fine. Good for them. But I think it'd be impossible to do in cardiology. Right?
Well, you're right. It comes down to the judges, and hopefully you could do this in a local way. Meaning, not nationally. Right. Meaning, hopefully the local, Philadelphia chapter would have some group.
Yeah, but the problem with locally is that then you have competitors. Which is very important. I think there are many cases. I'm sure that there are cases where people get accused of practicing outside the norms by competitors, and it's infighting and vendettas and turf wars and that's
that's a great point. Any system can be gamed, so you'd have to be very very careful.
Correct. So I think there has to be, and if it's, ideally there would be competing independent boards of evaluation.
Right.
It's an intractable problem. There's no easy solution. It's always the problem of who guards the guardians.
Yes.
But at least if you let it be, and if you allow different competing guardians, if you will, and they have to, demonstrate and prove that they are independent. They do a good job. But again, who right now in this current in our current structure or system, who's interested in that data? Again, it's always going to be the payers and the regulators. It's not going to be the patient directly.
The thing is, Michel, I wonder sometimes if maybe we do have a system that is, we have whistleblowers. It's not like we have not had cardiologists go to jail or...
Right.
And so it's not like, I don't, but the problem is, it's this undefinable scope of the problem. Some people,
but
David Brown has said that,
we need to accept that, right. Yeah. If somebody thinks that they can devise a system that will eliminate people from taking advantage of patients and whatnot, save us from these utopians, because really, we have to recognize that there's not going to be any system that's going to.
Well, I brought up the fact that perhaps we need to go even further upstream, meaning I am perhaps, this whole culture of pass equal MD, meaning whether you're a medical student, resident, fellow, when was the last time a fellow was not allowed to become a cardiologist? Has that ever happened?
Yeah, that's right. You're right. Right. Correct. No, that's a very big problem. Very big problem. There's a little bit of, I think, attrition in medical school, perhaps. Yeah. But once you in residency, that forget it. You're in. You're guaranteed out. I don't know exactly what part of it. I think is maybe labor laws, and I'm not sure what is your sense about that? That everybody automatically gets.
I think it's the culture. I think it's a culture. I think we're all very complicit. I remember being a chief resident, and we would have this conversation, and we had this conversation about what to do with residents that were significant problems that we were concerned in terms.
But I think program directors are afraid of lawsuits.
Yeah,
And
lawsuits
there may
and
be lawsuits that about wrongful termination.
yeah,
Also,
well, especially if
residents
the
are
lawsuits
right.
especially if the lawsuits involve certain demographics. So I mean, if
Right.
you are, yeah, there's, if you're a woman, if
Correct.
you're a
Correct.
minority,
But I think in general, like, they're going to be squeamish about firing
yeah,
residents,
yeah,
and so everybody essentially gets a pass.
right,
There's also an incentive to give. Residents are cheap labor,
labor, yeah, yeah,
so I mean, people don't want to. It's just it's been a culture, and everybody is so overburdened in general. I mean, as much as clinicians are overburdened, administrators are overburdened as well, and they don't want any headaches, right? They just
right,
want to,
right,
at the end of the
right,
day, they want to go home and, and
right,
not create any
right,
problems. So
right.
so yes,
I think,
they get a pass,
I,
and they're not medical schools and residency programs are not held accountable for the quality of their graduates. It's something
yes,
we
yes,
discussed in the past. So there's
right.
no incentive for the residency programs to churn out. It's very indirect the way.
Yeah.
So it'd be,
Yeah.
oh,
So
it's about.
I think that is where we need to fix this problem. I don't think
I
once you
agree.
have,
Correct.
I
Correct.
had a coach, a good friend of mine a long time ago said, you can't, whatever you do, you cannot polish turds. And, you know, once you're out and you have somebody with significant problems that's out, it's incredibly hard no checklist takes
Right.
somebody that has fundamental difficulties with cognition, putting things together. I don't care how many checklists you give that person,
Right.
they're going to do harm.
Right.
So this is,
Yeah.
I think we need to go much further upstream and change the culture in terms of who becomes, and certainly for the fields that the stakes are very high, where mistakes made, whether it be neurosurgery, whether it be interventional cardiology, whether it be EP. I mean, any blockhead can become a non-invasive guy like me. I'm allowed to say that, right? Because I'm a non-invasive guy. But you and Jay Schloss and Jay Geary and all these procedural guys. I think where just it's incredibly important. If you make the wrong decision, you can really do a ton of harm to patients. And I think we need to
right. I mean, I think
group.
I think it goes across specialties. I mean, I don't know that certain specialties are more. Perhaps that's the. I mean, maybe. I mean, I actually joke that the medical device industry that gets so vilified, right, has done things so easy that really you can have a monkey do an angioplasty for the most part. So
well, no. Yeah, no, it's not so much the procedural. It's what goes on before you pass
the decision, right? The decision before you get
that decision making is incredibly important.
But general cardiologists are part of that decision, and primary care physicians are also part of that.
I was only half.
Right.
I'm only half in jest. I think you can do a lot more damage in 30 minutes with a catheter in the heart, certainly, than I can. But you're right. I mean, if you make, as a generalist, it's important to make the right decisions, send patients to the right place. So yeah,
right.
Venk Murthy is going to be very upset with me. So I was 3/4 joking.
Well, we'll let him comment on that. Yeah. Anything else? Have we haven't solved that problem, I don't think.
No.
But we've, I think, identified its futility. I think, I'm afraid.
Yeah. Yes. Again.
It's futile. We need to pull the plug on public reporting.
Yeah, I don't. That's what I don't get. Why are we so? Until we figure it out, why? I mean, if people are being harmed, Khurram Nasir, who's a population health guy, I would think he would be especially susceptible to these net benefit, net harm arguments. That, hey, look, I mean, there's no evidence of significant benefit. There's probably evidence of harm.
Yeah,
but why are we continuing this?
Because admitting that undermines the whole edifice. It's really, if you admit that, it undermines, because the whole edifice is built on the presupposition that you can, and here I'm talking generally, or whether we're talking about medical school graduates or residents or whatnot, or even third-party payments. It all is predicated on the idea that you can objectively identify, but metrically, you can sort of quantify the quality of care. And so there's a huge industry and it's vested interest. And, I mean, if they admit their error here, then the whole thing crumbles down and departments get shut down and and that's the end of it. So that's why I don't see it happening. I think they will always say, like Krumholtz, says, well, let's all get together. I appreciate the feedback. Yes, we quality measures are imperfect, but we can do better if we put our heads together. If we all work together, because it's all for the patient, right? so that's going to be the reaction, and it's going to be another round of. The problems with risk. I have this paper from 1995 from the post-Clinton reform debacle, and all the problems that we've talked about were identified back then. They were. Everybody's aware of them. It's been. Yeah, it's not a secret.
Yeah, that music that you hear playing, Michel, is the pulp reporting ship that has hit the glacier, and the quartet or whatever is playing as the ship is sinking. So right. So that I guess the tweets from the sounds from Khurram Nasir and Harlan Krumholtz sound to me like the sound of the violin.
We can hope. All right, Anish.
Yeah,
let's end here, and I'll see you next time.
Yep. Take care.
Bye.